Good afternoon, students. So, today we are going to discuss about anti-anemia drugs. I have already told you, and through assignments and through various instructions I have given, I will just move it very fast because it's very easy chapter. There is nothing special into it, and therefore you can go through it. Only guidelines wise, very important guideline is whenever the hemoglobin drops below 8, then the blood transfusion is recommended, and if still goes down, then very prompt, or what we can say, emergency care that has to be taken. These are two very important guidelines, particularly related to hemoglobin level. We know about anemia, and we'll move through it. If you have difficulties, then you can put it. So we know about hemopoietic system, what are various cells and how various nutrients are playing a role into it. What is anemia? Again, we know about is that is reduction in the hemoglobin, hematocrit or RBCs. Anything which is there, basically it is related with the whenever there is anemia, it is going to cause tissue hypoxia, because either hemoglobin is less or the hematocrit, that is when we centrifuge it, whatsoever amount of RBCs is settled down, we call it as hematocrit or RBC number. So anything is less or all are less, or anything any of that can be less, then it is anemia, and because of that it will reduce the oxygen carrying capacity. That is a problem. So there are various types like microcytic, megaloblastic, pernicious, hemolytic, aplastic sickle cell and sideroblastic anemia. Why there is anemia? It can be because of the diminished production of replacement of RBCs, excessive breakdown and loss of RBCs, hemodilution, which is not a cause of anemia, but it causes anemia. Like hemodilution means this too much water is there and blood is diluted rather. So this is anemia like effect, because effectively per volume of blood the red blood cell reduces. So what are the reasons behind diminished production and replacement of RBCs? So microcytic shows deficiency of iron, and because of that it will appear pale RBCs and smaller and more reticulocyte. Now for that again you have to understand hemopoietic system. Actually I have put it in our WhatsApp group that please go through hemopoietic system, our hemopoiesis. So reticulocytes, it is a previous stage where the nucleus is present and the nucleus is expelled. So you go through it, then you will understand it. It can be caused by the chronic use of aspirin, which causes irritation of stomach, and there is a blood loss into it. And again absorption of iron can be reduced. Then normocytic anemia, number of cells or RBCs are normal, but erythropoietin is deficient, and basically it is occurring because of the compromised renal function. Now what is the relation between renal function and anemia? Because erythropoietin is produced in kidneys, and whenever there are kidney injuries, kidney damage, which actually causing renal failure, acute or chronic, but simultaneously it is also causing reduction in the erythropoietin. Again, erythropoietin you must have seen in anatomy physiology, and its role in production of RBC. So this is a normocytic anemia, that is number of cells are reduced. Then next is macrocytic anemia. Macro means bigger, so cell will be bigger. So deficiency of folic acid will cause the macrocytic anemia, because cell division will be diminished, reduced, and therefore larger cells will be there in the circulation, but their function will be reduced, and therefore anemia. Now second cause, bigger cause, is breakdown of RBCs. So it may be because of bleeding, maybe ulcer, or in female during menstrual cycle females are having. So usually during that period females may have less hemoglobin. Use of drug that causes irritation of GIT like aspirin or any other drug which is producing ulcers. Hemolysis, like the drug which is causing hemolytic anemia, maybe during blood transfusion we are having hemolytic anemia. Autoimmune diseases, during heart wall, microvascular diseases can be there. Some toxins like snake venom, this can cause it. So there are drugs used to treat anemias, we call them as hematinic, which improve the RBC count or hemoglobin count. We call them as hematinic, which improve heme. So these are iron, vitamin B12, cyanocobalamin, folic acid, erythropoietin. Now there is no big pharmacology for that, and therefore this chapter is easy, because we have seen various anemias, why they are resulting into. So if you diagnose it, then go for that particular supplement. If it is microcytic, then go for iron. Okay, if it is kidney failure, give erythropoietin. So this is what the guidelines are. Okay, therefore it is easy. Guideline wise, same pharmacology you are going to apply. This is the knowledge. If it is because of the vitamin B12 deficiency, give vitamin B12 or cyanocobalamin. These are various drugs. So go for this. Then this is what erythropoietin pathway, how from kidney it is released, and how it plays a role in bone marrow and RBC production. So this is what erythropoietin and its analogs. Where the site, this is actually the pathway of synthesis from the stem cell, that is pluripotent stem cell we call them. This pluripotent stem cell, there are various factors are there which are acting. These are actually interleukins, are tissue growth factors, and these all various factors they are acting. Then we are having colony forming units at various level, and we are having various colony forming this stimulating agent. We call them as a CSF or GM-CSF. So these CSFs are what? Colony stimulating factors are there. CSF, this is not CSF which you see in CNS otherwise. So these CSF are colony stimulating factors, and they improve the colony forming unit, and this is the pathway of what we can say RBC formation. So here you can see how reticulocytes are there and what are various stages, and on which stages various interleukins or various CSFs they are acting, and accordingly each stage is process, each stage is followed, and it results into RBC formation. Now you can understand that RBC, we know lifestyle is 120 days, and if this regularly formation is not there, it doesn't mean that after 120 days every cell is all of a sudden all the cells are getting damaged and new cells are there, or they are phagocytosized or apoptized and they are new are formed. Actually there are certain fraction of cell which will what we can say form new today. Some will be there this hour, some will be in next hour, some will be in next hour, like that. Whole month or whole for 3 months this cycle will be reduced. The cell which are formed today will be about in 120 days, near about 120 days, this cell will be replaced with the new cell, and same will happen after whatsoever form after 2 hours or after form which are 3 hours or 4 hours, like that. So these cells are there, these will be formed accordingly, and this will indicate that how big the turnover rate can be with this. So because of that, all these agents which are required, all these various interleukins and colony stimulating factors and various growth factors, they will be continuously needing, and even any small deficiency can result into malformation of erythropoiesis. So these are very important. These are various biological actions of various hematopoietic growth factors. So example of these are granulocyte macrophage, we call it as GM-CSF, colony stimulating factors. The synthetic analog or the available analog of this is SAR-gramostim, which acts synergistically with interleukin 3 to stimulate the formulation and proliferation of colony forming cells, or CFUs, colony forming units we call, and it increases the cytotoxic phagocytotic activity of mature granulocytes. Then there is interleukin 3, there are interleukins, these are the cytokines, and they play important role. It acts synergistically with erythropoietin, and it stimulates the formation of these BFUs, E colonies. Then it induces the colony forming unit S and leukemic blast cells into cell cycle. Again, you must be aware about blast cells. Blast means these are the immature cells. Okay, and when we put it site, that means a mature cell. Then other colony stimulating factors, CSF1 or AMP-CSF, that is it acts synergistically with this granulocyte, macrocyte, CSF, and interleukin 3 to stimulate monocyte macrophage. So only monocyte macrophage it is acting. So we call it as a MCSF, and G means only granulocyte it is acting. So these are various CSFs. They are available nowadays, fortunately, and they can be used in the treatment whenever the problems are there. Now these problems particularly are more in the cancer treatment. Again, after that you are going to study, or you are going to have the various things, that is agents which are having impact on the blood and hematopoietic system. So all the anti-cancer drugs, they are affecting, because they are affecting the rapidly developing cells, and you have seen that these RBCs or various blood cells are rapidly developing. So in that cases, these cells will be affected most. Then other hematopoietic growth factors, thrombopoietin, this is TSF, that is tissue stimulating factor, increases the size and number of these megakaryotes, is one of the cell which is megakaryocyte during erythrocyte formation. It increases the concentration of early megakaryote cells in the bone marrow. It produces increase in the megakaryotes endomitosis, that is, it increases the mitosis of it. It increases the platelet size and number of platelets in the, and therefore it is called as a thrombopoietin. Other is erythropoietin, you know about it. It is very popular as epoietin, and various brand names are available: Epox, Zyprop, Eprex, etc. Various units are available. It is one of the colony stimulating factors, specifically acting on erythrocytes, or it is increasing the erythrocyte activities. The agents like filgrastim or pegfilgrastim. Filgrastim is again one of the branded colony stimulating factor, and PEG filgrastim, that is, it is dissolved in the polyethylene glycol, and therefore it is sustained release is there, and it will be available in body continuously. I told you that continuously you need CSF, because the stages are continuously occurring, and therefore these are required. So accordingly, this PEG cell filgrastim, that is comparatively more preferred, because it will be acting continuously, and no repeated injections will be given. So these are various factors and interleukins which are available. So erythropoietin is a cytokine which is produced in the juxtatubular cells in the kidney, and also it is produced in the macrophages. Nowadays it is available because of the recombinant technology. Last year you have studied about genetics and recombinant technology. It is available as epoietin alpha and beta, and it is given in the units like 25 to 100 international units per kg, subcutaneous or intravenously. Uses are there during chronic renal failure. I repeat, it has nothing to do with renal failure. It is not doing any impact on the renal failure, but since during renal failure the kidneys which are producing erythropoietin, they will not able to produce, and we are replenishing it. During cancer chemotherapy, why again I told you, during cancer chemotherapy the cell division is affected, and we need additional boost for the cell division. During this AIDS, anemia caused by treatment like AZT, that is azithromycin, we call it as AZT, and zidovudine, etc. So these are the drugs which are causing suppression of bone marrow. In that case it is there. In premature infants where the RBCs are not sufficient, during blood transfusion to increase the RBC level for autologous blood donations, means same person has donated blood for himself before surgery, and then after some days surgery is being done. Anemia associated with the rheumatoid arthritis. The adverse effects are flu-like symptom, mild hypertension, encephalopathy, occasionally convulsions, risk of thrombosis due to hematocrit rise. Hematocrit rise means RBC level increases too much, and then it causes increase in the thickness of blood or viscosity of blood. So this is the iron cycle. This is biochemistry. Will not go for that. You can just have a look, or you can learn it in biochemistry. So there are various iron deficiency anemias because of either dietary deficiency, because of the faulty absorption, because of the transport, because of the storage, because there are various stages which are there as it has shown in this. So some of these are absorbed. There are some proteins which are required for absorption, for transportation, and for storage. So when these proteins are less, then either absorption will be affected, or transportation are affected, or storage will be affected. So these will be there, then these will be affected in the excessive blood loss, maybe injury, accidents like that, or surgeries. Then due to worm infestation, this will not be proper one iron, and then people will cause it. Maximum iron absorption will be through duodenum and jejunum. Heme iron and non-heme iron will be there. Ascorbic acid, then thiols, SH group, that is, these are various amino acid having thiol, succinic acid. They are important for conversion of ferric to ferrous. So these are the iron related thing. How much diet should be there, and around 10% of the dietary absorption, that is around 1 to 2 milligram per day, is absorbed, and that has to be provided through various food supplements. So important is it is required for the it's important contributor in the hemoglobin, that is around this heme, that is iron. The globin molecules are there, and that makes there, and it is important for oxygen binding and oxygen transportation and carbon dioxide transportation. So if it is not there, then it will cause macrocytic hypochromic anemia. And absorption I will not discuss in more details, because it is sort of biochemistry, and you can go through it. Transport again I will not discuss. I told you there is one protein example, transferrin is important for that, and that will be there. Then next is, this is how cycle is there. Iron is there, it is absorbed, it is converted into ferric one, and it is ferric to ferrous, it will be there, and this ferrous will be absorbed, and this ferrous will be taken up by the ferritin, which is required for that transportation, and thus it will go. Then transferrin will be there, it will be responsible for transportation to liver, and from liver it will be going to various tissues, where it will be stored as a ferritin, hemosiderin, etc., and it will be present in the bone marrow as hemoglobin, will be muscle as a myoglobin, and these other tissues, and cytochrome P450 system, which is for enzymatic system. So 75% will be bound to hemoglobin, and oxygen transfer 10 to 20% goes to storage pool, which is recycled as erythropoiesis, and storage and use are balanced. So I told about storage, ferritin molecule. Then therapeutic uses, particularly it is used in iron deficiency anemia, hookworm infestation. Again, it is not making any treatment of hookworm infestation, but since because of the hookworm, or we call it as anthelmintic infections, the person will have deficiency of iron, and therefore it has to be given. Pregnancy, malabsorption syndrome, that where the person cannot absorb the things properly, and because of that iron, even though it is there in the diet, it is not absorbed. Premature babies during blood loss, and bleedings due to ulcers, aspirin, and excess consumption of coffee. These are various bleedings. In that cases, iron has to be used. Oral iron is available as a ferrous sulfate, and parenteral is available as a iron dextran, particularly where the person cannot get the absorption of the iron. That in that condition, this is used. It is cheapest form, and adverse effect: nausea, vomiting, then abdominal pain, constipation, or diarrhea, and this will cause painful injections at the site when it is parenterally given. And if iron is not absorbed, then this injection has to be given. I told you it is a painful one, and it will give blackish coloration near the site. So these are the oral formulation: ferrous sulfate, ferrous gluconate, ferrous fumarate. These are very economical, and parenteral are iron dextran, iron sucrose, iron sodium gluconate, etc. Oral iron therapy, already I discussed you. These are various side effects: nausea, vomiting, epigastric discomfort, constipation, diarrhea, etc. And these are dose related. Those who cannot tolerate it, then they may go for parenterals. This can be given in addition to the oral iron when you need iron replenishment too early. In that case, this has to be used, because then this will be important because oral takes long time, and particularly in some patient absorption is not proper, or all these molecules are not there. In that case, it should be used. So these are various preparations. Side effects of iron is headache, lightheadedness, fever, arthralgia, nausea, vomiting, back pain, flushing, urticaria, bronchospasm, and rarely anaphylaxis and death. Hypersensitivity reactions may be delayed for 48 to 72 hours. In some, particularly parenteral, it is there. And small test dose should be always given of iron dextran, and then it should be given. So these are various agents. This can be given only by intravenous route, iron sucrose or sodium gluconate complex, and they are much less likely than iron dextrose to cause hypersensitivity, and therefore they can be recommended intravenously. If the hypersensitivity is high, then intravenously we cannot recommend. So these are the requirement, iron requirement, daily requirement. Various pharmacokinetics already we have seen earlier, how it is converted to ferrous to ferric, then it is dissolved, and then again it is absorbed, how ferrin binding. This is biochemistry, how it is released from this binding proteins like ferritin and transferrin, and how it is made available in case of emergencies. Hemosiderin granules are seen with the iron overload, and it gives rise to hemosiderosis or bronze diabetes, and dot or purpura can be seen into these people. Treatment of iron deficiency, already we have discussed various drugs. These are the various agents which are there. Again, these are drugs and their brand names and tablets which are there: ferrous sulfate, ferrous fumarate, ferrous gluconate, collodial ferric hydroxide. These are various preparations. Now, apart from ferrous, we have seen that some vitamins can be less, and in that case, and they are very, very important in various biochemical reactions during that. The important are vitamin A, D, A, K, the B complex group like B1, B2, B3, B5, B6 and biotin. Particularly hematopoietic B complex vitamins are there. Usually they are given. B complex means this B1, B2, B3, B5, B6 and biotin and B12. Folic acid and cyanocobalamin, they are very important, and non-B complex groups are there like ascorbic acid, that is vitamin C. These are various important. One, vitamin C is very important. It is added into hematinic formulation for various purposes. It is as an antioxidant. It is playing very important role in biochemical reactions of this heme formation. Then next is vitamin B12. Again, it is important. It is required for normal DNA synthesis, and it is absorbed through GIT through two mechanisms: intrinsic factor and mass action. That is, we call it as passive one. But for that, very high dose has to be given. It has to be absorbed via passive diffusion, and the low dose it requires intrinsic factor in stomach, and then only it is there. So many times deficiency is because of the problems in the functionality of this intrinsic factor, because so much high dose is not given. These are various preparations of vitamin B12 like cyanocobalamin, hydroxycobalamin, methylcobalamin and 5-deoxyadenosylcolamine. Accordingly, we have got different pharmacokinetic parameter. As I told you, at low dose, whenever it is given, intrinsic factor is required for active transportation. Then there are transcobalamines are there, and they are important in various metabolic functions. We'll see their therapeutic uses. Daily requirement is around 2 to 3 microgram per day, and therapeutic dose is 100 to 1000 micrograms per day intramuscularly. So it will cause peripheral neuropathy and macrocytic anemia, which is sort of a pernicious anemia. Folic acid administration can correct the microcytic anemia, but will fail to correct the peripheral neuropathy. To treat the neuropathy, vitamin B12 has to be added into it. Mechanisms for peripheral neuropathy: it is a cofactor for the enzyme methylmalonyl CoA mutase, which is converting methylmalonyl CoA to succinyl CoA, and it enters the Krebs cycle and goes to nervous to make myelin. So if it is not there, then myelin will not be made, and therefore we call that neuropathy will be there. So if there is no vitamin B12, it will produce abnormal fatty acid, and it will cause subacute degeneration of nerve. and only B12 can correct this problem. Therapeutic uses of B12, we have seen pernicious anemia, neuropathy, then corrosive injury of GI mucosa, fish tapeworm, in that it is there. Placebo abuse is there with B12, particularly in elderly patients. Abuse, like it is given as a placebo, kuch nahi hua to B12, because it does not cause any problem like that. It is failed, but again this is not correct. It should not be given like this. Various derivatives, as I told you, cyanocobalamin is actual vitamin B12, but it says that is brand name Redisol. Then other analogs are hydroxycobalamin, methylcobalamin. These both are given. This methylcobalamin is available as a both formulation, oral formulation as well as injectable formulation, while hydroxycobalamin is available as a parenteral only. Then folic acid is available. Folic acid is available as pteroglutamic acid, and this folic acid is playing important role. I hope you remember last year you might have studied in sulfonamide that how it is contributing in the folic acid and tetrahydrofolic acid, how they are contributing in the DNA synthesis and various one carbon transport, we call it as a. So please go through the biochemistry to have better idea. And this folic acid is required, we have seen in anemia. It is present in source various food like yeast, egg yolk, liver and leafy vegetables. Then folic acid is absorbed in the small intestine. It is converted to tetrahydrofolate by dihydrofolate reductase. We have seen it during antibacterial drugs or sulfonamide trimethoprim. That deficiency is also called as a Wills disease. The deficiency may produce megaloblastic anemia, neural tube defect in the fetus, and therefore folic acid has to be given in various conditions like megaloblastic anemia to alleviate anemia that is associated with the dihydrofolate reductase inhibitor. Example, methotrexate is given in cancer treatment, pyrimethamine is given as antimalarial. Administration of cytooram factor like methylated folic acid, that will alleviate or that will not cause the anemia when it is used in these conditions. It is also useful in the anemia because of the ingestion of the drugs that interfere with the intestinal absorption and storage of folic acid. So example of these are phenytoin, progestin, estrogen. They will not allow folic acid to get absorbed, and therefore that will form this conjugation. So inhibition of the conjugates that break up folic acid and from its food, and it gets chelated. So in that also we have to give it. Malabsorption like sprue, celiac disease, partial gastrectomy. In that condition absorption will not be good, and therefore we have to supplement it. During rheumatoid arthritis there is increased folic acid demand and utilization, so it can be given. Basically folic acid and B12 are dependent on each other, and therefore both are simultaneously given, so that whenever B12 or folic acid related problems are there, both can be solved simultaneously. So these are various preparations. I think we have finished. Hello. बरं चला, ऑल द बेस्ट. हां ओके. बरं हां काही अडचण नाही, काय अडचण मग काय अडचण नाही, काही कारणच नाही इकडे यायचं है ना. चला ऑल द बेस्ट सगळ्यांना. कोण कोण आहे तुम्ही? बरं चला नाही चला, ऑल द बेस्ट है ना. ओके चला. So here we finished anemia, various treatment. I told you there is nothing big into it. Depending on the signs symptoms, you have to select the drug, and various symptomatic what we can say criteria are there to diagnose. As its name itself indicate, macrocytic or megaloblastic reticulocytic. So this name indicates these are the diagnostic features also. On that basis one can identify which kind of anemia it is. So go through it, these various anemias which having different kind of sign symptoms, or rather different kind of size, shape, color of erythrocytes, you can get it. Others are there, example sickle cell and all. We have seen these kind of anemias, basically they are because of genetic problems, genetic disorders, and in that conditions, basically important thing is the care has to be taken. Blood supplements has to be provided to these people, and second thing is the care has to be taken that such people, when they are getting married, they don't have they are not marrying with the partner who is also having a problem, because otherwise the chances of having progeny with this genetic disease will be more. So this is another thing which is very important with that. These are all various kind of anemias we have studied, and the treatment, as I told you, it will be on the basis of the diagnosis. As the anemia is, according to the treatment will be. Basically, most of the time there is a common tablets are there, usually along with iron, vitamin supplements are there, where vitamin B12 and folic acid is there. So almost simultaneously everything is given. Only in case of renal failure, even if there is a good iron, even if there is a good vitamin B12, still erythropoietin is required, and therefore additionally erythropoietin has to be given. Same thing is there if you think about various platelets and related. So thrombopoietin we have seen, because these are important in the this thrombopoietin, or CSFs are there, we have seen colony stimulating factors, they are available, example filgrastim and all. So they are important in that. So go through this pharmacology. If you have any difficulty, you can ask. So here we have finished anemia also. Now we know about various drugs. We have encountered various drugs earlier and their effect on blood, because you have studied pharmacology in second year and your third year. In that, in most of the adverse reactions, whatsoever drugs are there, you know about it, and many times you know causes also. Example, we have seen that anti-cancer drug, almost all anti-cancer drugs, they affect the cell formation. So these all things are known to you. Have a look on that, go through that and see what are the drugs which are affecting blood. So in various manners these drugs are affecting. You can go through it, you can have this as an assignment. So next time we have finished all this topic actually. So next week anytime we can go for examination about this topic, because syllabus sessional we have kept these topics pending. So once this is also, if you have any difficulty about drug induced blood diseases, you can have it, you can put it, you can find the best article over that and share it with that. The best article we can find, or best thing you have done, accordingly we'll consider it as a template. Okay, go through it, make the note on that, and next week anytime we can try to conduct the test. Practicals you can have it, if, as I told you, whenever I get time you can invite me also. If I am not free, then you please continue with it. If possible, keep the record, and all the group will write all the at least you will make your notebook ready with that. Your one notebook you will be making about it, in which you are recording individual view, group view and class view. Individual view means student A is the part of group of 3. So student A, what the student A feels, so they will note my individual view. Then student, once they will meet in group, they will discuss about it, and suppose in group A, B, C 3 students are there. If A, B, C all 3 are having different view, then they will put into the 3 view, they will collect it together, they will compare, and there are chances that all 3 views are correct, but there are conditions in which they are correct. So mention it, either one is correct, one is latest, one is old, one is more appropriate, one is less appropriate, or all 3 are appropriate. Whatsoever it is there, you mention it, and on what basis you are thinking this, and then you present this. So whenever you are discussing this case, convert it into SOAP format and accordingly go for that. Okay, if you can make PowerPoint, well and good. If you cannot, or if you don't have time, there is no compulsion from my side. Only my basic concern is you should understand about that case nicely. Whatsoever case is there, you have to assume that you are the clinical pharmacist working in certain hospital, and doctor has got a faith in you, and doctor has referred the case to you. you always think in that way, then only you will able to. If you take it as a ritual कि therapeutic practical में cases करना है इसलिए कर रहे हैं, then definitely I am not sure that what knowledge you will get. But if you are thinking in this way, that this case has been referred to me by the physician and I have to think over it, it is a matter of my stake, it is a matter of my knowledge, it is a matter of my reputation, then definitely you will work in that way and accordingly you will write the notes. So this will give you idea that what kind of notes you should have written. I told you, you can refer Koda Kimball, you can refer books are available on case studies. So what's your books are there, in that you can find it out. In case Koda Kimball, actually at least 1 or 2 cases are given about every type of disease. So go through it, and at least one of you should take Koda Kimball case. There how you can go through how the nice illustration is given about various cases, that actually what is the situation, although everything looks correct, but then after what thinking it needs to change, or what a clinical pharmacist that should have a thinking or should think about. So you go through it and start in that direction. So all the best. If you have any difficulty, you can go and you can put it on group and ask. I hope I have clarified everything. So should I leave now? Okay. Thank you. All the best.